Can high-flow nasal cannulas being used in the community for critical care patients in the community? That's the question I'm going to answer today. My name is Patrick Hutzel from intensivecareathome.com. So one of the questions that we get from our clients and also prospective clients is, how can high-flow nasal prongs or high-flow nasal cannula being used in the community for critical care patients? And we are certainly doing that, and we have been doing that for a long time with Intensive Care at Home, with our critical care nurses, where we have got clients at home on a device for high-flow nasal cannula. So let's look at some guidelines, how we use them for one of our clients that has been nicely documented by one of the physiotherapists that we are working with. So respiratory physiotherapy care plan guidelines and supportive information for a particular client. Support documentation for all of the client's caregivers subject to clinical assessments of the intensivist and the CCRNs, as well as the cardiorespiratory physiotherapist for this particular client. So the high-flow nasal prongs airbow machine was referred for by the respiratory therapy with the MyAirbow 2 initially by the client's speech pathologist due to the client retaining secretions in his lungs and recurrent hospital admissions for pneumonia. Now, that was before we were providing services for this particular client. We pretty much stopped him going back to hospitals because prior to our intensive care at home service for this particular client, he was in and out of hospital and he more or less lived in hospitals. And I remember the day when the family actually called me. I had no idea who they were, but the client's family pretty much started the call with, you have to help us, they're going to kill him in hospital. And that's pretty much how how much need this family was in, because the client could not be kept at home with support workers or even with general registered nurses, but he was more or less living in hospital, and the family was living in hospital, and they are very traumatized because of that. So we could put a stop to that, of course, with our intensive care at home service, and the client has improved their quality of life big time. So let's continue with the description of how to use the high-flow nasal cannula machine, the airbow, at home. The primary purpose of the MyAirbow 2 therapy is to facilitate clearance of secretions, phlegm and sputum from the client's lungs and make it easier for him to cough it out. It also increases lung ventilation and elevates oxygenation. And prior again to our involvement, he had lots of chest infections, pneumonias, and he ended up going to hospital all the time because nobody could use the airbow. Obviously, us as critical care nurses, we know how to use the airbow. We also know how to do deep suctioning, which is often what is needed for the clients. The MyAirbow 2 machine provides humidified air and a gentle positive air pressure through nasal cannula wide nasal prongs. The nasal cannula are also referred to as the nasal interface or just interface in the product manual. All caregiver staff working with the client need to be familiar with this machine and its application for the client within the scope of their practice. In the MyAirbow 2 manual that has been supplied with the machine is a very useful reference. All critical care registered nurses from intensive care at home should just spend 10 minutes to become familiar with the manual. It is not necessary to read the whole manual. Check that a printout of the English section of the manual is at the bedside in the client's home. CCRNs must know that the software of the MyAirbow 2 differs from the Airbow 2 used in acute settings like in ICU or in hospitals. This is because it is programmed to better fit home usage constraints. All CCRNs, or all intensive care at home CCRNs, including night staff, are invited to text or call the physiotherapist, which I want to thank very much for the involvement with this particular client, but also with other clients. To receive targeted initial MyAirbow 2 training, all staff are also invited to call the physiotherapist whenever they have questions regarding the airbow application and prescription for the client or his respiratory physiotherapy. The client's baseline for my Airvo prescription temperature is 31 degrees, flow 30 liters per minute, room air target oxygen saturation as per the intensivist, 94% or above. The overnight usage is aimed for 8 hours overnight. More is fine if the client can tolerate it. Daytime usage aimed for 3 hours during the day, depending on the client's schedule and tolerance. Daytime Airvo usage may be during TV time or sleep or rest time. It is important that baseline usage not impact quality of life and lifestyle activities. And what goes hand in hand here is also often normal saline nebulizers and to loosen up secretions, and then also doing deep suction if the client can't cough to avoid, again, chest infections or even a pneumonia, and that is the critical care nursing skill in a home care environment to prevent that and manage the unstable airway. Choice My Airvo 2. The client's My Airvo 2 prescription changes when he's sick or has been sick within the last 72 hours. Is needed, the CC and the CCRNs are qualified and authorized to change the settings on the My Airvo 2 without prior consultation with a doctor or the respiratory physio. However, it is important that communication of the changes is made to intensive care at home as well as the physio and the intensivist. Clinical autonomy of CCRNs when clinically indicated and as assessed by the CCRNs. Respiratory interventions may be indicated by the CCRN at their discretion, such as, again, initiating also saline nebulizers as well as deep suctioning, but also chest percussions and chest physiotherapy, again, to loosen up secretions. The guidelines here are not intended to restrict the autonomy of the CCRNs managing unique clinical situations, but only to serve as a general and supportive guide and facilitation for team communication. Also, the guidelines can be subject to change, thus this is a fluid or can be a fluid document. The guidelines are subject to instructions by the intensivist and also subject to the clinical assessments and decisions of the CCRNs and also the intensive care specialist and the respiratory physiotherapist. Next, respiratory treatment is graduated. The CCRNs monitor the client and may adjust treatment in response to changes. This includes applications of My Airvo 2 and oxygen together with titration to clinical targets for the client. Respiratory interventions ramp up as per clinical indications and accordingly ramp down. Monitoring facilitates more gentle gradient to ramping of treatments in the event of a respiratory emergency. God forbid, guideline respiratory emergency response example as advised by the intensivist last month. For response to an episode for severe hypoxia, apply oxygen to the My Airvo, turn oxygen up to 15 liters per minute, increase flow on the My Airvo to 50 liters per minute if needed, call the ambulance for attendance, call intensive care at home, of course, call the intensivist. And the CCRNs can apply and titrate emergency interventions as indicated. And document, of course, when practically determining oxygen concentration when supplemental oxygen is in use via the My Airvo 2. And of course, part of this is ongoing communication for monitoring with the respiratory physiotherapist as well as the intensive care consultant, as well as with our clinical leadership team here at Intensive Care at Home. Other respiratory physiotherapy interventions identify higher risk times of the day or situations such as early morning. Example, early morning is a higher risk time for the client. This is due to sputum accumulation and thickening overnight. Potential observations could be reduced oxygen saturation, abnormal breathing such as noisy breathing, audible rattling of secretions, increased breath rate, labored breathing, and visible oral secretions, coughing, facial expressions or agitation or distress, and also, of course, a lower oxygen saturation or a higher heart rate. Prophylactic management for higher risk times or situations. Example, again, early morning to reduce the early morning risk for the client. These are suggestions only and are subject to the CCRN's assessment and capacity at the time. Close observation on wake-up time, including oxygenation, starting with gentle movement upon waking, i.e. assist with side-to-side positioning, add arm exercises for improved benefit, gentle movement of the uppermost arm inside lying. This facilitates sputum transportation and clearance, assisted sitting over the edge of the bed, if able. Arm exercises as described by the physio. Note that arm exercises, in particular arm elevation, flexion, encourage spinal extension, increased rib expansion, deeper breaths, and may stimulate effective coughs. Applications: normal saline nebulizers, suction for clearance of secretions. Consider reapplication of airbow oxygen and other interventions if needed to aim for oxygen saturation of 94% and above. And of course, clear breathing with dry cough and non-productive. Morning lung auscultation from our CCRNs at the practical time without disturbing the client, such as when first sitting out of bed. Contraindication for manual percussion and vibrations. Note that manual percussion and vibrations are contraindicated for the client due to osteoporosis. Osteoporosis greatly increases the risk of rib fractures with these physiotherapy techniques. We are currently investigating for a mechanical fine vibration mat or a vest to assist with airway clearance techniques in the future for the client. Next, if oxygen saturations above 94% cannot be achieved, of course, gradual ramping up of interventions if oxygen saturation falls below 94%. Close monitoring and earlier interventions may help to avert more major intervention. Younger people have higher normal oxygen saturations than the elderly, so we intervene sooner, respond according to clinical assessments such as suction, application of my airbow 2, consider increase of flow, application of oxygen via my airbow 2, normal saline nebulizers, change of body positioning, i.e. sitting in the wheelchair or partial stand with a tilt table. Tilt table therapy and benefits, by the way. The assisted partial standing with a tilt table provides major respiratory benefits, in addition to numerous other health benefits. The diaphragm drops to a lower level. The tummy contents also move downwards, giving less upward pressure upon the diaphragm. The spine is encouraged to extend more, which facilitates increased expansion of the ribs and increased thoracic volume. The net effect is that the lungs automatically take deeper breaths with increased lung volume in this position, reduced risk of lung collapse. Coughs are more effective. Oxygenation is elevated. Overall ventilation is improved. In addition, although difficult to measure, the increased ventilation can assist in breathing out the correct amount of carbon dioxide or CO2. Next, it stimulates increased alertness. Next, there is some evidence that the standing position can improve bladder function as well. Studies have shown that standing promotes improved bladder emptying and reduces the incidence and severity of bladder calculi and urinary tract infection for people in wheelchairs. Next, musculoskeletal benefits, improved weight bearing to lower limb joints and bones, promoting improved health of articular cartilage and bones. Reducing progression of osteoporosis, stimulates activation of some muscles needed for basic core strength in this position that are not activated in other more sedentary positions. It also promotes normalization of blood pressure control. Goals with the tilt table therapy: number one, guided by a neurological physiotherapist. As with all exercises for the client's physiotherapy and exercises are subject to the client and the discretion of the CCRNs. The client's consent or implied consent, quality of life and lifestyle activities take priority over the tilt table therapy. Taking all of these points into account, these are the current goals to work towards. Short-term goal, half an hour daily, planning for progression to long-term goal, half an hour in the morning and again in the afternoon. Monitoring of tilt table therapy, chart to record daily. Time on the tilt table can help to progress towards these goals. Next, identification of any problems with managing the tilt table can be recorded and passed on to the relevant physiotherapist or to the intensivist. By identifying problems as a collaborative effort, we may be able to optimize the support for the client and also support the nurses, whilst balancing the goals with other issues and priorities. When the client is suffering respiratory illness, the need for his time to be upright with the tilt table increases. At the same time, he may present concerns or contraindications for the tilt table. Please discuss these with the intensive care specialist and also keep the physiotherapists in communication and in the loop. Other aspects are that the client is benefiting from nebulized saline in promoting airway clearance about 3 times daily or as needed. The client may benefit from prompt positive reinforcement of his deep breaths and strong coughs. And if the CCRNs can make him smile and laugh, the reinforcement is likely to be enhanced. Encourage every effort suction of secretions as required. Any caregiver can seek guidance and support from other CCRNs to check techniques. At this stage, the client does not have a home visiting respiratory physiotherapist for face-to-face support. However, this is another respiratory goal for the future. Here is another tip. When you're going for a drive with a client like this, driving on a gravel road also has some benefits than driving on a smooth one for sputum mobilization and airway clearance due to the benefit of jiggling and vibration for the lungs. And of course, fun, laughter, and happy things. Positive mental stimulation. Physio exercises initiated by the physio, including both upper and lower limb exercise, hydrotherapy, and also provision of explanation and seeking of consent for physiotherapy. It is understood that all CCRNs and caregivers seek permission and provide explanations prior to all physiotherapy interventions as far as possible for the client. And finally, all of these interventions are often followed by deep suctioning, either through the nose with the nasopharyngeal airway or either through the mouth with a Guidel airway. So, with intensive care at home, we are currently sending our ICU and critical care nurses into the home 24 hours a day. We are providing the following: home care services for ventilated adults and children with tracheostomies with critical care nurses 24 hours a day. A genuine alternative to a long-term stay in intensive care or long-term acute care. We're providing tracheostomy care, home care services for patients on non-invasive ventilation, such as home BiPAP, home CPAP. We're providing services for home TPN, also known as total parenteral nutrition, which is also known as IV nutrition. Also, home IV potassium and home IV magnesium infusions, IV fluids and IV antibiotics. We're providing central line management, PICC line management, Hickman's line management, as well as port management at home. We're providing nasogastric tube and PEG tube management at home, cough assist machines for our clients for airway clearance at home, palliative care services at home, as well as ventilator weaning at home. We're also sending our critical care nurses into the home for emergency department bypass services. We have done so successfully as part of the Western Sydney Local Area Health District, their In Touch program, saving approximately $2,000 per patient that we keep at home instead of them going to an emergency department. That also means we're in a position to cut the cost of an intensive care bed by around 50%. An intensive care bed costs between $5,000 to $6,000 per bed day. Our service costs between $2,500 to $3,000 per bed day. And we're freeing up the most sought after bed in the hospital, which is the ICU bed. Most importantly, we're improving the quality of life for patients and their families, which is a win-win situation for all stakeholders. Of course, quality of life is much improved surrounded by families instead of staying in an intensive care unit. With intensive care at home, we're currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We are an NDIS approved service provider all around Australia, TAC and WorkSafe in Victoria, DVA, Department of Veteran Affairs, all around Australia. Our clients and we as a service provider have also received funding through public hospitals, private health funds, as well as departments of health. We are currently the only service provider in Australia that has achieved third-party accreditation for intensive care at home nursing in 2025. We have been achieving this level of accreditation since 2012. No other provider in Australia has created more intellectual property when it comes to intensive care at home nursing than we have. This puts us in a position to employ hundreds of years of critical care nursing experience combined in the community. No other service provider in 2025 employs a higher skill level in the community than we do which enables us to look after the highest security adults and children in the community in Australia safely. If you are at home already and you're watching this, or you're stuck in an ICU, or if you're going to hospital and ED all the time and you realize that you don't have the right level of support at home, or if you're living in an ICU, I'll give you a very tangible and real-world example today. One of our first clients, when we first got started in 2012, was a client who was at home initially on a ventilator with a tracheostomy with a support worker model 24/7. Of course, support workers are not equipped to look after a ventilated and tracheostomy client. That is dangerous and it's negligent. Having support workers looking after a client at home on a ventilator with a tracheostomy is like flying the airplane with a cabin crew instead of the pilot, because anyone on a ventilator with a tracheostomy is at very high risk of medical emergencies 24/7, or even at risk of dying if they don't have a team of critical care nurses looking after them 24/7 at home. This is actually evidence-based and is documented in our mechanical home ventilation guidelines that you can find on our website at intensivecareathome.com. Think about it, in an intensive care unit in a hospital, you wouldn't have support workers looking after your critically ill loved one or after any critically ill patient on a ventilator with a tracheostomy. So why would anyone in their right mind would do that in a home care environment in the community? So this client found out about us eventually, and the ICU that he went back to all the time also knew about us and eventually reached out to us, and we were proving our concept with this client very fast. When we worked with this particular client, we sent him intensive care nurses 24 hours a day, and he never ever went back into ICU ever again, as long as we were working with this client. We can do the same for you if you're not safe at home, and help you with keeping you at home predictably. Otherwise, we wouldn't be in business. The same is applicable for those stuck in an ICU, similar to this case study that I've given you. Or if you're going back to ED all the time, please reach out to us. We can help you with taking you through the right steps, including how to get funding with different funding bodies. This is also why we are providing level 2 and level 3 NDI support coordination. We have a team of NDI support coordinators, and they have a wealth of knowledge. I've done an interview with Amanda Richards, one of our NDI support coordinators, and I'll put a link to an interview with Amanda in the written version of this blog. We're also providing TAC case management in Victoria. If you're an NDI support coordinator or a case manager from another organization watching this and you're looking for nursing care for your participants, please reach out to us as well. And if you need more evidence for nursing care, we're also writing nursing assessment, NDIS nursing assessments with legal nurse, critical care consulting nurses. And if you are a critical care nurse and you're looking for a career change and you want to join a very progressive, dynamic, and high-performing team of critical care nurses in the community, we're employing hundreds of years of critical care nursing experience combined, and you can join this high-performing team. If you're looking for a career change, we're currently hiring for jobs for critical care nurses in Melbourne, Sydney, Brisbane, in Albury-Wodonga, in Bendigo, in Geelong, and in Warragul in Victoria. If you have worked in critical care nursing for a minimum of 2 years, pediatric ICU, ED, and you have already completed a postgraduate critical care nursing qualification, we will be delighted hearing from you. I do have a disclaimer though, because we are offering a tailor-made solution for our clients, which includes regular staff. Our clients also do want the same staff coming over and over again, because they are so vulnerable and so special, and that's why we need regular staff. So if you're looking for agency work where you can come and go, this will not be the right fit for you. We are looking for consistency, and our clients are looking for consistency. So please only apply with us if you can give us regular and consistent availabilities for shifts, and you're really keen on building solid relationships with us and with our clients. And if you're an intensive care specialist or an ED specialist, we also want to hear from you. We're currently expanding our medical team as well. We can also help you eliminate your bed blocks in your ICU and in your ED for your long-term patients, or for your regularly readmitting patients with our critical care nursing team at home. We're here to help you take the pressure off your ICU and ED beds, and in most cases, you won't even pay for it. Even if you do pay for it, it is so much more cost-effective than what you're paying for in ICU and ED, and you get the same level of care. If you are a hospital executive watching this and you have bed blocks in your ICU, ED, and respiratory wards, or home TPN, please reach out to us as well. We can help you eliminate your bed blocks very fast. If you're in the US or in the UK and you're watching this and you need help, we want to hear from you as well. We can help you there privately with one-on-one consulting and with hiring nurses privately. Once again, our website is intensivecarehome.com. Call us on one of the numbers on the top of our website or simply send us an email to info@intensivecarehome.com. And if you like my videos, subscribe to my YouTube channel for regular updates for families with intensive care at home and intensive care. Click the like button, click the notification bell, share this video with your friends and families, and comment below what you want to see next or what questions and insights you have from this video. Thank you so much for watching. This is Patrick Hutzel from intensivecarehome.com, and I will talk to you in a few days. Take care for now.